Welcome to Octavia's Cure. I'm Dr. Stella Safo, and today we're talking about something healthcare systems say all the time, but still struggle to consistently build: care that's truly designed around people and that really centers individuals in reaching their health goals. We often hear phrases like patient centered care, health equity, healthcare transformation, but too often those ideas sometimes stay at the level of language and theory instead of becoming real in the lives of patients, especially patients that are navigating some of the greatest barriers. If we want better outcomes, we have to ask better questions like, who is this system actually designed and working for? Who's being left out? And what would change if we designed healthcare with people instead of simply delivering care to them in mind? That's why I'm glad to be joined by Sonia Panigrahy. Sonia is a public health strategist whose work sits at the intersection of healthcare operations, human centered design, and health equity. She spent years helping organizations understand not only what the data says, but also what people's lived experiences reveal about where care breakdowns happen and how to build something better together. So, Sonia, welcome to Octavia's Cure.
Thank you. I appreciate you inviting me to have this conversation.
I'm so excited to have you because we hear these terms a lot and I use them
Yes.
a lot, and I live in this world, right? And sometimes I'll be talking with patients and I just get the sense like, wow, patients don't realize how much of design work is happening around them and how often they're being kind of left out of that. So before we jump into all of this, I would love to have you describe to us what all the different parts of your career are: this public health part, this human centered design part, healthcare transformation, just in like everyday language. What does that mean? Tell us a little bit about your career journey.
Sure. I got my master's in public health about 20 years ago. And in that role, I did an internship at a large academic hospital center, trying to understand why pediatric operating rooms were running 3, 4, 5 hours late. And I came in and was asked to just look at the data. And I realized that the data we were looking at was actually missing the patient's voices and also the clinician's voices. And by talking to folks, I realized, we try to improve systems, we try to improve outcomes, but often we don't include the people who are closest to that experience. So I found my way kind of after grad school working in different hospitals, community health clinics. The New York State Primary Care Association oversees all of the community clinics statewide, um, doing a lot of quality improvement work, performance improvement work, looking to improve population health outcomes, and realized that we were missing an important piece of information, and we didn't have ways of getting missing information from the patients and the staff to understand why they were kind of challenged with going through a journey, trying to, complete a type of care journey to help them get better outcomes. So I did a pivot just away from the traditional quality improvement methods, which honestly often comes from manufacturing, and decided to study human centered design, which is a method that's existed in tech and product development. Apple Technologies came up with this. It's making sure that we are focusing the way we design services and products with the user in mind. And in healthcare, the user is often the patient, but it's also, the person who's providing the care.
Hmm. I
So
love that sorry, I guess I love this part that you mentioned that oftentimes QI work is in the manufacturing world and human centered design is actually meant for humans and that the tech world uses it, because I was just thinking like
yeah,
the experience of using a really well designed like Apple product, for instance, right? It just feels good. And I don't think most people get that experience from walking in their healthcare journey. And I'm not saying that we should, you know,
yes,
tech grow our healthcare journeys, but there's
yeah.
something about the ease that certain places kind of give you, certain services that we just don't get in healthcare. So I love the way you frame that.
Thank you. I actually use this example quite a bit where I've been in conferences and physicians will say, I shouldn't be blamed for what my patients don't do. And then have the example of an iPhone. And I would say 2-year-olds can figure out how to use an iPhone. our grandparents figure out how to use an iPhone, and they all do it without a thick user manual.
Hmm.
And Apple would not be where they are now if they just blamed the user to say, oh, well, they're non-compliant, they're not educated, they're not figuring it out.
Hmm.
Apple is where they are is because they intently studied people using their product and kept refining and kept redesigning it so that the iPhone is as simple and seamless as possible. It's intuitive. It meets
Hmm.
our needs before we even realize it. And I would love to bring this type of a mindset into healthcare. So we're
Yeah.
not blaming patients for not, you know, taking better care of themselves. We're understanding what patients need in their own lives. They're an expert in their own lives. They often know what they need and they often know the solutions. We just need a better way of finding that information out and centering people's needs in the way we design healthcare.
I love that. And I want to say, because I'm mad at all capitalistic institutions, that we are not endorsing Apple per se, right? But just as
Yes.
an example of something that works and is intuitive and meets people where they are. I'm
Yeah.
curious, as we're talking about being patient centered, this is a term that's thrown around a lot. And I'm curious, in practice, where do you think health systems most often fail to be truly patient centered, and why does that happen? And I'm asking it because a lot of people who are listening and thinking about how we design these systems better are like, well, no one's asked me, the patient, what I want. And so I want people to start to think, like, how do I get into these spaces alongside health systems that are saying they want to be patient centered? Help us understand why that kind of falls apart.
Oh, that's a great question. Agree with you. We often use a term patient-centered, which means we center our care on patients' needs, yet we never ask the patients what they need. I think we're often very paternalistic in healthcare. We assume patients don't know what they need, or they're just not educated enough or not motivated enough. And in my work, I find that to be completely false. Um, I find when we don't use human-centered design, um, or other methods where we're bringing in, patients' insights, it's often because we prefer to protect the status quo. We
Hmm.
want to protect the existing structures, the existing power, existing roles. Um, and let's be honest, part of that existing structure is the way healthcare is financed.
Hmm.
I often say we are insurance centered. And that goes also to the way we treat our clinicians. And it also goes to the way we shape patient care. It's not really for what patients need or want, it's shaped on how we know we're going to get paid.
Yeah, and we talk about that a lot with the electronic medical record, because some
Yes.
of these big electronic medical records were created not for the ease of use by clinicians so that they can care for patients, but for the ease of billing. And it makes
Yes.
sense, right? If you don't bill appropriately, you can't keep your doors open. But my goodness, if health is a human right, how do we design it so that we can pay people adequately and they can actually deliver the care that's needed? I'm curious because
Yeah.
we've said it a couple of times, and I want people to get a really good sense of what we mean by it. Walk us through what you do when you're doing human centered design and how that happens within healthcare.
Yes. So some of what I do is I work with primary care practices who are looking at population health outcomes and try to enhance their quality improvement to embed human-centered design. We never want to just uproot a process that's already working and again meets their financing needs. But at the same time, I say with healthcare, when we are trying to understand our problem space, we have to be honest about how traditional methods fail or are deficient
Mm-hmm.
and work to find other ways to adapt and translate that into healthcare. I think one prime example is the use of technology. I think we really
Mm-hmm.
try to speed ahead with digitizing everything, digital apps, using technology to replace some of these human interactions. And I will say, in terms of an equity lens, let's pause and figure out who this technology is not for.
Mm.
And I've done this work with telehealth access. So, with the pandemic, a lot of healthcare systems had to invest in telehealth infrastructure. And it was a means of bringing access to patients, which is a good thing. And about 2 years after the pandemic, I worked with some clinics in New York to try to understand why there wasn't greater adoption. It didn't
Mm.
make sense. We have this technology. Wouldn't it be easier, especially for older adults, people with mobility issues, people, there's an anti Asian hate crimes, Some of the clinics had mostly an Asian population. So
Hmm.
how do we make sure that they are able to access care safely in their own homes and not disrupt, their course of care? And so what we did is we actually went and asked patients if they were interested in receiving telehealth, if
Hmm.
they knew that was even an option, if they said yes, understanding what that experience was like for them, and if they said no, understanding why they chose not to get a telehealth visit. And it was interesting. We understood from just pulling data that um, largely females and people 45 plus were not using telehealth visits, even though it was
Hmm.
available to them. And by segmenting different groups of people, we understood that the different groups of people had different attitudes, thoughts, perceptions, and needs.
Hmm.
And once your clinics understood that you respect diversity by creating different cohorts,
Hmm.
doing a deep dive into what their experiences are, you can then tailor your needs a little differently. I feel that when we just force people into a one size fits all
Right.
average, we exacerbate inequalities. So, we found for older adults, they are still tech savvy, but when it comes to doing telehealth, it's a new technology. It requires
Hmm.
multiple steps. The steps are not explained to them. They're worried about this text message link that might be spam.
Hmm.
Once we knew like that was why they were resistant, that helps the clinic to understand, oh, they're willing to use it. They just need some extra, you know, um, support, a little hand
Hmm.
holding, maybe a tech navigator to help them use the technology. Also heard from different groups of people, they were worried they weren't getting the same quality of care from
Hmm.
telehealth, from certain perceptions and clues that they were picking up in their visit. So once you understand those hesitations, you can be better um, equipped to support patients to get the care that would be beneficial.
And that seems
Same,
so intuitive. So, there's a moment where I'm like, well, why aren't we doing that more? I know why, because I'm in healthcare and I know how busy and intense but why do you think that folks don't get those insights quite as much? Well, where do you think that that's coming from? Is it a lack of understanding the approaches of human-centered design? Is it a lack of time? Is it kind of all of the above? Like, that sounds so intuitive what you've described, and yet we don't do it. How can we fix that?
I think in healthcare, we're a very low resourced, high pressure environment. People are really kind of looking at short term strategies. And so sometimes we're just looking at the needs in front of us right now.
Hmm.
I think the work I'm describing requires a little bit of a longer strategy. Let's take a pause, let's do some research, let's understand what patients need um, to be able to redesign systems to see longer term outcomes.
Hmm.
But let's be honest too, our healthcare system is not financed to really care what patients or physicians need or want. It's
Hmm.
about getting people in and out the door.
Mm-hmm.
Um, I think we also don't really have the methods to know how do we do these qualitative studies in a healthcare setting and to break away from this idea that it has to be evidence based or we're using the
Mm-hmm.
scientific method, that we have to have large sample sizes. So I even feel
Mm-hmm.
from the medical scientific community, they're not always bought in that this information is going to be useful or trusted to make changes.
And that makes a lot of sense. I remember the first time I learned about, PDSA's Plan, Do, Study, Act, which are small tests of change. My feeling was, but we're only talking to a handful of folks, like where's the IRB approval? Where's the,
Right.
the generalizable cohort? And I think that that often prevents us from being agile with getting information that we need to get.
We'll return to Octavia's Cure after these messages from our sponsoring partners.
Healthcare and democracy are more connected than we often acknowledge. The Civic Health Alliance is a nonpartisan coalition working to deepen the connection between healthcare and democracy. And we do so by helping healthcare workers and communities get civically engaged so that health becomes part of how we show up as citizens. Right now, CHA is running the 1,000 Caring Voices campaign, mobilizing health professionals and community members to advocate for policies that protect patients. If you believe that a healthy democracy leads to healthier people, this is your community. Please learn more and join us at civichealthall.com.
And now, back to the podcast.
One thing that I think that you have always done really well for me is, I'm always kind of like, well, what do the patients say? What are the patients? What are the patients? And you'll say, and also, what about the frontline staff and clinicians? And I think that your work pays such close and beautiful attention to that group as well. Why do you think it's so important to understand that part of the healthcare experience? And how do we make leaders and those who are paying for healthcare and those who are, determining kind of how healthcare is delivered, how do we make them care about frontline staff and clinicians who are facing incredible amounts of burnouts, mental injury, especially as we're seeing some of the federal legislation that's coming out, of late. I'm curious about how we like deal with that group when sometimes it feels like they can often be thought of secondary or last.
No, you're absolutely correct. And I think this is where I differ from people doing human-centered design in healthcare. So I will say you can't focus on your patients only without thinking about the people who provide care for them. You know, even if you want to think about a healthcare product, like an app that you want your patients to use, it has to go through your physicians. And your physicians have to feel like A, there's value, B, it works within their existing workflows, and B, they're getting paid for it. There is a saying, the quickest way to get people to not do something is to not pay them for it. So we need to make sure that our clinicians are adopting new workflows and new work that fits within how they are currently incentivized. I'll also say, I feel like the physicians I know and work with truly do care about providing good patient care, and they need
Hmm.
supports. They know what they need, but they need an administration who takes the time and has the courage to ask how physicians can be better supported. And when I say physicians, I also mean all clinical and non-clinical staff. I often talk about
Hmm.
the care team,
Hmm.
um, because if we cannot keep a staff that are satisfied and feel like they're able to do the best care possible for their patients, we will continue to hemorrhage clinicians out of the workforce. I think this idea of physician burnout and moral injury is prime for a human centered design project. We
Hmm.
need to start asking our clinicians what they need. And I think administrators are afraid what the answers might be and are afraid that the
I was
answers
just
may
gonna
be.
say. Hmm.
And when I talk to administrators, are afraid clinicians will say, I want more salary, I want more flexibility. I think clinicians also want appreciation,
Hmm.
and some support that are often not monetary.
Hmm.
But there are things that the administrators could do. They just don't know because they don't ask.
Hmm.
It's a,
I think that that is brilliantly stated. Like, there is a teaching in healthcare that you don't necessarily apply a tool or do a diagnostic evaluation if you don't have an intervention, right? And so it's a similar thing, right? We're not going to evaluate with our healthcare workers kind of what they need if we don't plan on doing anything about it. And yet, some of the solutions are simple. I'll tell you what doesn't help us as a primary care doctor are like the endless pizza parties and like crafts that we get as thank yous. I remember after COVID, I think we got like a token, and I was like, man, like those are the things that kind of just feel like, wow, that's so far from what we would want, which is like maybe a few hours off a week, or just something that just shows a deeper understanding of the sacrifice and the ways in which we are working so hard to meet the needs of our patients. And so, just that the beauty of asking, I think, is really present in the work of healthcare improvement and certainly in using human centered design.
and if I may ask, the asking shows empathy, it shows
Hmm.
curiosity, it shows that you're willing to um, open yourselves up to criticism. But if you know that the end goal is making sure that you have a workforce that is happy, satisfied, productive, and wants to stay, again, that is a long term outcome that will be beneficial. So I think that is the investment that healthcare needs to start realizing,
Hmm.
is that we keep cycling these problems and we keep putting out solutions that are working for no one. It's
Hmm.
wasting resources. We have very limited resources. And we keep perpetuating these problems that are frustrating everyone at every level. So I think we, desperately need to pause and understand, what do people actually need so that we could design better systems, um, to have a better experience all around.
So One thing that I think is cool is that a few years ago, because of the Affordable Care Act, thank you, Obama, health systems started to move towards a system of population health in terms of their payments or
Yes.
value based payments. So they said, you
Yeah.
know, you won't get paid. Insurers and other payers said, we won't pay you based on every single visit. We're going to pay you based on the value you're
Yes.
delivering to your patients. And so if you can take care of your patients with diabetes and help them get their diabetes numbers to a good level in one visit, you'll get paid just as much as if you take 3 or 4 visits to do that, right?
Yes.
It's based on the outcome and the value. And the idea with that is that it was really meant to help rather health systems to change their way of operations and to change the way that they were approaching healthcare delivery and to improve quality overall.
Yeah.
I provide that background because not everyone is aware of the population health movement and what it's really meant to do. And I want to ask you, now that we know that Pop Health and the Affordable Care Act and some of the payment mechanisms are different, we know that health systems, some of them at least, not all of them, are trying to do things a little bit differently. They are trying to focus on prevention and overall health outcomes. How do the users that you've talked about, patients and frontline staff and clinicians, how do they get more involved in that work of healthcare improvement in a time where there is a little bit more flexibility with population health? In other words, if you're someone who's listening to Octavia's Cure and you're like, oh, it's so cool that, health systems are trying to deliver care in a way that really meets like better health outcomes versus just like, per visit. I want to be at the table. What does that look like? How do they get involved?
Oh, that's a amazing question. Yeah, this idea that we incentivize health systems for better outcomes is something that Europe has already been doing. They've
Mm-hmm.
realized that the healthier the population, you should see a reduction in hospital beds. Um, Again, this politically, this country is different. We're still newer and making mistakes. Seems like we're not learning from them, but it's a process. Value-based care is a way of tiptoeing our way towards kind of the European method. One of the examples of kind of getting into this space is looking at health systems that have a population health focus. Now that we're a little more data mature, we do have databases and platforms that can look at population level data. In the community health space, they're already doing value based care with Medicaid managed care plans who give report cards on preventive measures like making sure our 2 year olds are immunized. We're doing, sexually transmitted infection screenings among our patient populations, keeping our diabetics in control, and providing quality incentive dollars if health systems meet those outcomes. So we have a place where people are being incentivized to focus on outcomes. Again, your databases can tell you what is happening, how much is happening, how many of our 2 year olds are not being immunized in the Bronx, which is a problem I have worked on. But you need human centered design, you need some qualitative insights, you need patient narratives to go and understand what are the factors behind patients who are hesitant or contemplating getting vaccinated. We assume patients are not educated. When I did some design work with health centers around vaccines, people are very educated around vaccines. They're getting education in different sources. And again, the more we understand why they're going to those sources and what those sources are telling them, we can better equip ourselves as a healthcare system to make sure that patients are making the right decisions. Um, I'll also say with value-based care, a common indicator is looking at patients who overuse the emergency room. So that is measured by 4 more times in a year. And again, without human-centered design and just looking at our data, we assume patients are not educated. Oh, we need to put in brochures about what a avoidable ER visit is. Oh, we shouldn't tell them to go, they are going for colds and flus. That's inappropriate. And actually, I did a study with a physician out of Cambridge, Massachusetts, and found that the majority of patients kind of broke all of our assumptions. They all had insurance, they had a primary care physician, they had a good relationship with
Oh,
that
that's
primary care
interesting.
physician. Correct. They knew that they should not be going to the emergency room, but they were left with no option.
Mm-hmm.
Often, when they needed care, it was after hours, and their primary care physician said, go to the emergency room.
Mm-hmm.
100% of our cohort were socially isolated due to some childhood trauma.
Hmm.
So I'm sitting here as a hospital administrator at the time saying, okay, like normally we would just make brochures and do what was easiest for us in the healthcare system. And again, making biased guesses about our patients that are again
Mm-hmm.
paternalistic and condescending. When patients are saying, I wish I could have a psychiatric nurse come to my home, or I wish I had another option. I wish I had a case manager or a social worker that I could talk to when I'm having a panic attack. I wish somebody could help me with my detox program and making sure I stay. I wish I had somebody who can help me with my employment, which is getting
Mm-hmm.
in the way of me not taking care of myself.
Mm-hmm.
So, all to say, I think it's looking at these problems that we know are impacting populations and being able to position yourself in a system that are looking at these outcomes, looking at inequity in these outcomes, and open to an approach where we're going and talking to people to understand what they actually need and realizing this will get you your long-term outcomes that will get you your value-based reimbursement.
And so I think it really is, to the point of what people can do. You can volunteer. You can say, and
Yes.
hopefully, when you're being asked for your opinion and your insights, you're being paid for your time. That is
Yes.
important. But
Yes.
don't just kind of skip back that past that table asking you for your experience as a patient. Like sit there and tell them, because to Sonia's point, those insights are so key to avoid us making biased assumptions about how healthcare needs to be designed. I want to ask you, as we're coming to wrapping up, I want you to tell me, because this is the imagining that we get to do on Octavia's Cure. I want you to tell me what you imagine needs to happen around healthcare design. And I think you kind of alluded to it a little bit, for us to get a better health and public health system. What is it that we need to permission and or make space for and or show up to do as a population, as healthcare administrators, as public health leaders, to be able to design healthcare systems better? If you could, have that God moment where you got to determine that, what are some of the elements that you'd really call out that we want to have to make it better for all of us?
I'm going to steal insights from the people I've interviewed. And I've interviewed like hundreds of patients over different kind of healthcare needs. And I will say, patients want to work hard and they are often motivated to take care of themselves, both with prevention and if they have an illness, managing that and managing that in a way that it is kind of natural without medication, without, major medical intervention. So I think if we understand that, I would love a public health system that focuses more on prevention and allowing people to access better kind of mobility, nutrition, care in their own neighborhoods. If we think about it, this is where the majority of people spend their time. It's not in a doctor's office. Ideally, it's at home. So how can we make sure that people have home environments where there is infrastructure provided by the public so that people have, again, like ability to exercise safely, eat well, um, have good guidance on how to eat well? That has come up quite a bit. They don't want a brochure. They don't need another app. They need personalized guidance on how to eat well for their conditions, their budgets, their lifestyle needs. I want to make sure people have consistent access to healthcare, meaning insurance. I think the fact that we have this employer based insurance system is completely broken, especially in this economy. When
Please
I,
say that. Please preach.
it is incredible. On a weekly basis, I'm meeting more people who are losing their insurance for their whole families.
Mm-hmm.
Families paying $4,000 a month to
Mm-hmm.
cover their spouse and their two children. People moving out of the country, and people I know who are trying to get on Medicaid, and with the subsidies being rolled back, still not affordable.
Mm-hmm.
And we should have a healthcare system that would benefit not just patients, but our hospital systems to have everyone insured and able
Mm-hmm.
to receive care as they need. Um, and I would love to see more research in women's health. We lack so much scientific information and training that I've seen a real desperate need to support women's health,
Mm-hmm.
whether it is fertility, pregnancy, postpartum, and post reproductive health. The age at which women are 40 to 65 is a huge drop off in research and care. And that is a
Mm-hmm.
really critical time to help women clinically and mentally take care of themselves so they can enjoy the longer life spans that they have compared to their male counterparts.
Mm.
Real need for mental health as well. I think if I were in a role to design a healthcare system, I would want to make sure every patient gets at least one annual medical visit, one therapist visit, one nutritionist, one mobility person, and a case manager or social worker.
Mm.
At
Please,
least
I want
once
to
a
live
year.
in your healthcare system. I mean, my goodness. Can you
You are
imagine?
welcome. Yes, yes.
That sounds incredible. And honestly, it's sad to see, but sometimes on Instagram or social media, you'll see folks traveling off for these medical visits where they can get everything that they want, kind of described as you've just said, in a place that offers that suite of those suites of, interventions. And it is sad that people have to pay thousands of dollars to go somewhere else to get that because it's just not affordable and accessible here, the richest country in the world. Like, what are we doing?
If I
Yeah,
may provide a
please.
quick example, I spent a couple of weeks in India. I went to Kerala, which is, where a lot of our yoga and Ayurveda comes from. And I met a woman from Seattle, again, probably has access to some of the best doctors in the US, if not the world. Her daughter, who's 21, had chronic gut issues, could never get them diagnosed or treated. They came all the way to India at a world-class hospital, got all of their services taken care of. And then she spent 3 weeks at an Ayurvedic retreat, and her daughter saw significant improvements. And I'll say, I am seeing across the United States, all demographics, people wanting to understand more about Chinese and Indian medicine.
Mm-hmm.
Information is not supported by the Western medical system,
Mm-hmm.
but I feel like this is an area ripe for opportunity is how do we provide access
Mm-hmm.
to some of these alternative treatments when the Western system has failed.
Mm-hmm. Mm-hmm. And can it be a both and? Can it be both
Yes.
alternative
Yes.
medicine and traditional Western medicine?
100%.
But I think those conversations have to be permissioned. I love your answer and the breadth and the kind of vision that you have for how we can make these systems better. And I'm so glad that someone like you with your training is in healthcare, improving it from behind the scenes and really guiding folks to understand how to ask the right questions and listen and then implement those into what we do. Sonia, thank you so much for being here.
Thank you for having me. I wish we had more time, but this was a great conversation. Thank you, Stella.
You're so welcome. Here's what I'm taking from this conversation. Words like quality improvement and patient-centered care start with essential functions of listening to what healthcare users are really asking for. And this allows us to move beyond assumptions, beyond what we think patients need, beyond what the metrics may dictate, to what patients are really needing and asking for in real time. Healthcare and public health systems are designed to get the results that they get, and so we can redesign them to get better results. Thank you, Sonia, for giving us the language and the approach to do that. She's reminding us that the people closest to the barriers and hardships are also often the people closest to the solutions. Thank you all for joining Octavia's Cure, where we keep imagining and building a more just future for health. Octavia's Cure is a production of Just Equity for Health. This episode was hosted and executive produced by Dr. Stella Safo, with creative director and producer Amanda Masidi, post-production and graphics by Simon Cowart, and digital content production by Devin Johnson. Learn more about our work at octaviascure.com. If you love Octavia's Cure, please subscribe wherever you get your podcasts and leave a review so more listeners can find us. Thank you.